Hello, everyone, and welcome to Cracking Addiction. My name's Dr. Ferghal Armstrong, and we have with us Dr. Richard Bradlow. So, Richard, I thought today we'd talk about stewardship as it applies to opioids, benzodiazepines, and other drugs that are potentially misusable. What is stewardship in terms of the context of opioid stewardship to begin with? I suppose.
I think the simplest way of describing it would be the responsible prescribing of a medication. But I'm actually going to answer your question with a question of my own, Ferghal. I'm going to describe an incident, an episode in time. I want you to tell me what it is. You have a drug that is immediately acting. It solves a biopsychosocial sort of formulated condition purely biologically. There's a huge push from it, from pharmaceutical companies and from the public. And it breeds tolerance, and it has a high risk of misuse and addiction. What drug am I referring to?
There are so many options to choose from. So you could be referring to an opioid or a benzodiazepine or a stimulant.
That is exactly it. I would say I would be referring to an opioid 20 years ago. I mean, I'm referring, as you say, all of these drugs all the time, but an opioid 20 years ago. Right. And during the opioid epidemic, I think it's really important to remember that nowadays we like to paint it and say, oh, it's the big bad pharma company. But there were a lot of pain medicine specialists saying this was, the pseudo addiction was out there. Or I could be referring to benzodiazepines 60 years ago and I'd cured anxiety. Or I could be possibly referring to stimulant medication now. But what I think it's important to note is with immediate acting medications, the patient notices the immediate effect. The clinician notices the immediate effect, and there's a huge push to prescribe them. And what's difficult in the room is to resist the urge to help the patient, because obviously that's what we all want to do. We all want to help the patient. The patient wants to be helped, and they're saying, please just give me that medication. And you have to say, I'm very sorry, but I can't do that because I don't think it's in your best interest. That, to me, is stewardship.
That is stewardship, and that's very difficult to do. I like the historical analysis. 60 years ago, 30 years ago, and the present. So let's go back to 60 years ago, right?
We will, but one more 60 years ago. What was the name of the first minor tranquilizer?
Well, I want to say diazepam, but obviously not.
No, absolutely not. It was a Milltown. Milltown was the trade name, the brand name. I think that's
chlormethiazole.
I think
was it a
so.
benzodiazepine?
It's not quite a benzodiazepine. But it's wonderfully named. Milltown was the name near the pharmaceutical company where it was invented, and so they just pulled Milltown, and it was such a hit, such a huge sort of societal hit. You could buy Miltinis in bars in California during that day. It was such a huge hit.
Right. So what was the active ingredient of this? What was the mechanism of action?
So I believe it was GABAergic. So it's meprobamate, which is GABA.
Meprobamate. Right. So meprobame's actually sold now as carisoprodol, isn't it?
I think that carisoprodol
it's a metabolite.
Is a metabolite of meprobamate, but rather meprobamate is a metabolite of carisoprodol.
Meprobamate is a metabolite of carisoprodol.
So meprobame's got a much worse overdose risk. Much worse window of therapeutic effect. So it went out, but it was the first minor tranquilizer. It was the blockbuster drug.
So before we go on, you must explain what a minor tranquilizer is and what's a major tranquilizer.
Yeah, and this I find really interesting because when was meprobamate, which was the first minor tranquilizer, when was it synthesized and first hit the market, Ferghal?
No idea. You're the historian. Tell me.
About 1950 in the 50s. So that would make you think that a minor probamate. So essentially, minor tranquilizer is a minorly acting tranquilizer. The concept of the word tranquilizer was come up with a guy that invented meprobamate, or named it after Milltown, after this town near him. And he thought tranquilizer, it brings tranquility. So that's genuinely, it's beautiful. It's a beautiful concept. So a minor tranquilizer is a essentially it defines itself about what it isn't, and it's not an antipsychotic. So a major tranquilizer is an antipsychotic. So if you think that you've got minor and major tranquilizers, you would have thought that the minor tranquilizers must have come along way after the major tranquilizers. And they thought, well, this brings about tranquility, but not in the same way. It's wrong. So the name tranquilizer comes from the guy that invented meprovimate. So it was actually invented for the minor tranquilizers, and they were both invented about the same time. So chlorpromazine, which was the first antipsychotic discovered in 1949, hit the market in 1950, 52. Big blockbuster drug about the exact same time in the 50s. During the 50s was the moment that the first antidepressants was discovered / invented. First antipsychotics.
What was
first
that
minor
one?
tranquilizers.
What was the first antidepressant invented?
So it's I believe it is an MAOI, but it's about by a year from the first tricyclic. So they were both invented at a very, very similar time to a completely different course.
So which MAOI and which tricyclic?
Oh, that is rude. I know I can't do which one. So it was so I could get there because it so the first tricyclic came out because they noticed, so it would be imipramine, wouldn't it? Because they noticed it from how did they discover tricyclic antidepressants, Ferghal?
No idea. You're the historian. You're the historian and you're the psychiatrist. You tell me.
So MAOIs, genuinely, it was just a Swiss pharmacologist trying to invent an antidepressant. Where tricyclics, they noticed that people getting ripe therapy and getting isoniazid got really happy. And that is why I say it's imipramine, because I believe imipramine the one that was the most
it's derived from isoniazid.
Yes, and tricyclics.
And ripe therapy, of course, is treatment for TB, so it's rifampicin, isoniazid, pyrazinamide, and ethambutol. Yeah.
Yeah, so ipranizid was the first one, but it is. That's so I was right there, but it is an MAOI. Anyway, I'm sorry, I don't want to waste the listeners' time. I'd have to look this up for. Sorry, I got distracted with. I'd have to look this up for. But that is the general path, and so it was wonderful. It was a gangbusters, and then weirdly in the 1990s it happened again. Right, you had SSRI sort of late 80s, and you had second generation antipsychotics 1990s. So it was a weird moment where we had this nothing for really 40 years, and then we had another gangbusters moment in psychiatric medication. We've gone right off. Sorry.
So we're talking about the 50s with the advent of tranquilizers, antidepressants, and first generation antipsychotics, right? Let's bring this back to benzodiazepines. Tell us the context of benzodiazepines and what they replaced. You know, why were they at one stage regarded as a safer alternative to something else?
Well, so I mean, it's really, really interesting. So I think there's two things there. I mean, to answer that question, it's barbiturates, which have a very steep dose response curve. So you are going to get they're more dangerous drug, and you can more easily overdose on them. But really, you could argue that this is one of the first examples of the tail wagging the dog, and it was really the pharmaceutical industry creating that need. So barbiturates weren't really selling in the same way benzos ever sold. This concept of the feminine mistake and Betty Friedan and the miserable housewife or Mother's Little Helper and the Rolling Stones are absolutely singing about benzodiazepines. So this concept was really invented by the time, like the pharmaceutical industry at the time. And the example that is prime for this is you would expect that if barbiturates are the sort of same GABAergic, less safe benzo, but in fact during the 50s, chlorpromazine and antipsychotics were aggressively marketed for the same thing. So really, it was the invention of these drugs that more, and in my opinion, led that rather than the sort of led the sort of creation of the market rather than barbiturates being too unsafe.
Right. But nonetheless, barbiturates are less safe than benzodiazepines. They have a narrower therapeutic window. So can you explain why that is?
Yeah. Well, I mean, so every medication has a dose response curve, and how steep that dose response curve defines how wide or narrow the therapeutic window is. But in this particular case, it's because barbiturates are direct acting GABA agonists, where benzodiazepines have an allosteric binding to GABA, which makes them very safe. In fact, if you're just taking benzodiazepines and no other sedative medication, your chance of overdosing is next to nil.
Yeah. That's a very important point. So benzodiazepines, including Valium, including diazepam, it's very difficult to overdose just on that if you're young, fit, and healthy. And that's because it requires something else to bind to that GABA receptor as well as itself for it to actually work. So there was an improvement in safety from barbiturates to benzodiazepines. And at the time when that, and irrespective of the reason why it happened, this marketing of benzodiazepines as a safe drug. With your historian and your psychiatric history hat on, or the history of psychiatry hat on, when did we start noticing problems with benzodiazepine use? Because there was one time when like 20% of all Americans were on benzos.
Yeah, so I think when did we start noticing is almost immediately. I mean, that song "Mother's Little Helper" by the Rolling Stones came out like 68, 69, almost immediately. I couldn't remember. I couldn't say off the top of my head when Mother's Little Helper came out.
I'm a little bit older than you. I'm a little bit longer in the tooth than you, and I can remember when I was in my 30s, so about 20 years ago. 2005, roughly. It was the first time when I really was instructed to start aggressively weaning people off benzodiazepines. Prior to that, there wasn't an issue, but really about 2005, certainly in the UK, we were actively encouraged to get people off benzodiazepines, and it was actually a mark of quality. It was a quality, safety, use of medicines issue for us to get people off benzodiazepines. And at the time, I was working in a general practice, and when we first started this push, we had like 200 patients on regular benzodiazepine prescriptions, and at the end of it, within 18 months, we got that down to about 5 people who were still on benzodiazepines, and they were all reducing. And look, the initial expectation was it would create holy hell and that there'd be a lot of suffering, a lot of pushback. But to my surprise, actually, it was a lot easier to do than I expected. But there was a reason for that. And that is, first of all, the polypharmacy, because people were taking multiple drugs, including benzodiazepines, and there was the overdose risk associated with the polypharmacy. Because we've already said that on its own, benzodiazepines are very difficult to overdose with. And the second reason was this dependency addiction issue. I mean, what did you notice the beginning of this, or did you always practice in the field of medicine where there was always the message, get people off benzos?
Well, I think two things there. I'm as you've alluded to, younger than you, and even younger. I think I graduated med school probably a lot later in my life than you did, so even younger professionally than you. And I think the other thing is that I don't think we're in that. So I teach psychopharmacology at Monash University with a brilliant professor who strongly believes that we should be prescribing benzodiazepines long-term for anxiety. It's not something I agree with him about, but it is. There's sound arguments for it. For instance, the anti-epileptic effects of clonazepam people don't get tolerant to that. So he would argue that as the anti-anxiety effects of that are also the same. I think when we're talking about pharmaceutical stewardship, is that's one sort of isolate. If you are in a sort of measured and isolated way prescribing benzodiazepines for long-term benzodiazepines for anxiety, which I don't believe is a good idea, but cleverer people than me do. And cleverer people than me also don't think. So I'm not on a limb. Is very different to having someone on an opioid and a gabapentinoid and long-term benzodiazepines. That is just dangerous, poor management. And I think that is where you can bring in pharmaceutical stewardship into that. And there was a wonderful study of Scottish people on opioid agonist therapy that I know we're both pretty familiar with that showed that if they were on benzodiazepines and methadone, their overdose risk was incredibly high. I think their relative risk of death was 4 times that of someone who was on a Suboxone and benzodiazepines, or someone who wasn't on benzodiazepines and was just on methadone.
Yeah.
So I think the risks to the patient are very real. And if you're not swayed by that, the risks to your clinical practice, because
are even realer.
Yeah, I've looked over cases where GPs are getting sued, or GPs are coming up against the APRA or the medical board for prescribing long-term benzodiazepines and opioids or stimulants in people with substance use disorders, and the argument there has been, by continuing the prescription, you are not helping them get help. You are continuing their addiction, and I think that's a real issue.
So I think it's important to emphasize the physiology underlying this significant elevation in mortality risk when you start co-prescribing benzodiazepines with other sedatives, and that includes alcohol, opioids, including methadone. But specifically with regards to opioids, there's 2 mechanisms in the brain by which we breathe, right? And the physiologists listening to this will suddenly say, well, actually, there's multiple, but I'm going to say there's 2.
Right? You've got many physiologists listening to this, Ferghal.
If there's a physiologist listening in, by all means, correct us. Right. You've got hypercarbic drive and you've got hypoxic drive. So the most important reason why we breathe is the buildup of carbon dioxide stimulates our breathing, right? But in people with, for instance, chronic obstructive pulmonary disease, people get tolerant to very high levels of carbon dioxide. And so then they rely on hypoxic drive to make them breathe. And that second, almost a backup mechanism, keeps people breathing and keeps people essentially alive. And the hypoxic drive is if you don't breathe, you deplete your oxygen level, and therefore the lack of oxygen then stimulates you to breathe, right? So on the one hand, you've got the buildup of carbon dioxide, and on the other hand, you've got the deficiency in oxygen. And they are both synergistic systems which keep you breathing. So opioids knock off hypercarbic drive. If you are taking an opioid, you become much more tolerant to rising levels of carbon dioxide, right? Benzodiazepines knock off hypoxic drive. So with the combination of these 2 agents, you completely wipe out both mechanisms that stimulate you breathing. And that's one of the reasons why the combination of a benzodiazepine and an opioid is so dangerous and really should not be prescribed other than in the context of a reducing regime according to the principles of stewardship.
And how much do you bring that into the room? Because it's a very difficult experience that we both encounter every day, saying no to someone, especially someone who often you quite like, and you are expressly there to help, and that's what you want to do. How do you deal with that situation? Because I should imagine for all the prescribers listening, that's what they want to know. It's an incredibly difficult situation.
So first of all, you have to go in with a mental attitude that you are going to practice ethical medicine, right? And the first law of ethics, I think you sit on an ethics committee, is that right? Or you teach ethics? Do you?
I teach ethics, but I'm terrible.
You teach ethics, right? I'm really. So I'm treading on thin ice here, but I'm going to say this: the first law of ethics in medical practice is primum non nocere. Yeah, first do no harm. It doesn't say secundum non nocere; it says primum non nocere. So you must not create patient harm. And if you think your patient in front of you is going to give you a hard time, heaven forbid that there's a medical catastrophe and your patient passes away, you will get a much harder time explaining your actions in coroner's court, right? So let's just put that into perspective. But there are only 2 reasons why you should say no to a patient request. One, it's not ethical or not indicated. And 2, it's illegal, right?
Yeah.
If it's illegal, well, you can rely on borrowed authority. But if it's going to cause harm, then you need to actually say that out loud. This is going to cause you harm. Therefore, I cannot agree to it. Now, the situations, that's fairly easy in terms of initiating drugs, right? But Richard, how do you manage the patient that you've inherited who's on a bucket load of benzodiazepines from a previous well-meaning practitioner who trained in the era when benzodiazepines were good, and for whom opioids were good for chronic non-cancer pain, and we still haven't got to opioids for CNCP yet. But how do you deal with that patient who's requesting just continue my script, doc? Let sleeping dogs lie. I've been on this for years. Everything's fine. What do you do for that?
So I think my approach is perhaps a little less highbrow than yours.
Don't say that.
I know very clearly what I want to do.
Are you doing the Spice Girls type of medicine? I'll tell you what I want. What I really, really want.
Or stop right now. Thank you very much. Need somebody with a human touch. Hey, you always on the run. Got to slow it down, baby. Got to have some fun. No, I think
I'm so old. I don't know what you're quoting now.
That was a different Spice Girls song.
Was that a Spice Girls song as well?
I think what I get more swayed by, what I have to be more vigilant against, is I think that in polite society, we are always responding to sort of social cues, and people are we are entering into, non-binding sort of verbal polite contracts all the time. And it's very difficult, especially in that situation where you're continuing. So I started at a new public opioid agonist therapy clinic at the start of this year, and I inherited a lot of patients that were getting treated in a way that's not in keeping with how the guidelines are. So too many takeaways with no urine drug screens, and I had to institute that. And that resulted in a lot of unpleasant conversations. And I think I would put it down to you just have to be polite, explain why you're doing it, and stay vigilant against being sort of cornered socially. So, I'll think of an example today where I had a patient who is old psychiatrist, has retired, and is on, from looking at the referral, some pretty irresponsible medications. And they called me to say, I won't see you unless you agree to continue these medications. To which I said, don't see me. I can't tell you what I'm going to continue without seeing you. But I think that's a very difficult conversation to have. And I can think of a lot of difficult conversations. I don't have a sort of secret to that. And I certainly often have been in the room with the patient who's persuasive and I like or I don't like, but I've agreed to do something I'm not comfortable with. And I think it's important to work in teams and to have a discussion about, why we did that, and to go back the next time and explain why you can't do that. But I also think it's important, to be making these shared decisions with the patient, even when you are doing something the patient doesn't want you to do. I think it's important to be really, really clear and open with them why you're doing that, and try and have as least sort of patriarchal relationship as possible.
Further to that, I would say that especially in the situation of the inherited patient where you're just not, you feel that the medication regime is not right, you need to exert your muscle. I know you can sense a mnemonic coming on. So you need to exert your muscle. So MSCL, right? Take out the vowels, muscle, MSCL. So a lot of the time, doctors feel that they can minimize the issue. You shouldn't minimize the issue. You should actually address the issue up front and say this. For instance, in the case of benzodiazepines and opioids, this will increase your risk of death by various pieces of evidence say various things. I say 10, you say 4, tomato, tomato, right? It's going to increase your risk of death. Do not minimize the issue. S stands for shifting. So once you've originally said no.
Hang on, you skipped U.
Oh, you take out the vowels. Muscles.
Oh, it's like a tech bros muscle. Okay, fair enough.
Take out the vowels. S stands for shifting, right? So what you don't do is say no and then shift your position after being bombarded with all the reasons why the patient wants you to. I mean, that's actually diagnostic in my mind of someone with a chemical dependence at the very least, if not an opioid use disorder. C, don't talk about comfort, right? The patient's in distress. The patient does not want to hear things like, I'm not comfortable with this prescribing. It's not comfortable for me. The patient doesn't care about your comfort levels. And L, I say, avoid lengthy explanations, because the longer that you talk, the more you'll fall into various traps that a clever patient is going to lay for you. So keep it short, sharp, and simple. Address the issue, and once you've made the assessment, you can take your time making an assessment. But once you've made that assessment, you've made the decision. Do not shift. Remember your muscle.
I think I want to add to that, Ferghal. I think maybe can we think?
You're going to give me a U and an E.
Yeah, well, I don't know. Well, what I find often, what I've noticed, and I think about a patient I recently saw, who then appealed to the head of the unit, who saw her later that week because she's very kind to me, and saw her. I was doing all that, and I was reducing their benzos, and I was very clear, but I was so locked in to saying my polite no that I didn't think of other things. And the head of the unit actually started a little bit of prazosin for nightmares, because she was separated from the argument the disagreement I'm having from the patient, and had that space to explore other things going on and treat that. So I'm going to chuck an E on the end of your muscle and say, and explore other issues.
Explore other issues.
Yeah.
Well, you got to find me a U as well, or anyone listening, find me a U for the muscle mnemonic, and we'll republish it in another episode. So let's talk about opioids, right? What?
Don't make it about you. You're fantastic. Yeah.
Let's talk about opioid stewardship. What is opioid stewardship? I mean, you mentioned you had a patient, or you work in a service where you instituted urine drug screening. I mean, what's all that about?
So I think opioid. I mean, this is really, really tricky as well. Because I'll answer the question, then I'll ask the question that I want to ask. So opioid stewardship is a responsible prescribing of opioids. We know that long-term prescription of opioids for pain does not work. In fact, it makes people's pain worse, and it puts them at risk for a bunch of other illnesses. But that is, and so then when I was referring to my opioid agonist therapy clinic, what I was specifically referring to is the Victorian government's guidelines. And I work in Victoria, so I follow the Victorian government's guidelines. And if I worked in a different state, I'd follow that state's guidelines. Their guidelines on safe opioid prescribing. And it includes stuff like, if you are going to give takeaways for your methadone, you should have regular UDSs. We do 3 monthly, as in one every 3 months.
What's a UDS?
Urine drug screen, beg your pardon. And that's because you want to check two things. You want to check that they are taking the methadone, because you don't want them to be diverting it completely. And you want to check that they aren't using
just a little bit. They can divert a little bit, but just not
a little bit. Absolutely. If it's in your urine, it's fine. You want to check that that there's not other sedative medications, especially in their urine, because you're worried about overdose risk.
And so if you do, so go on after you.
So my question is that I've been sort of thinking about a lot because of a case recently, is, let's say I was a GP, or I was me, and for some reason I got into a situation where I was prescribing opioids for chronic pain into someone with an existing opioid use disorder, right? But I'm just prescribing opioid agonist therapy. Am I doing... So I'm not prescribing opioid, I'm prescribing an agonist, like I'm prescribing morphine or oxycodone. Am I doing that much harm? Because this is what is separating me from prescribing regular morphine, oxycodone for pain in someone with an existing opioid use disorder from me prescribing methadone?
It's perfectly legal and perfectly appropriate to prescribe opioids for pain in someone with an opioid use disorder, even if they are in receipt of opioid agonist therapy. The key thing is the nuance in there is actually what kind of pain, right? But in terms of the legalities, if you've got someone with an opioid use disorder in Victoria, they need to be diagnosed as such and they need to be notified to the Department of Health. If you are then subsequently going to prescribe that individual opioids for pain of any kind, you need a permit. And if you don't have a permit, that's when you're going to get stuck. The next issue then becomes, is it appropriate to prescribe that opioid to that patient? So you need to ask yourself, why am I prescribing an opioid to a patient with an opioid use disorder? What are the reasons why it's appropriate to do that? And the fundamental answer is it's appropriate to give anyone, even if they have an opioid use disorder, it's appropriate to give anyone an opioid for pain if they have nociceptive pain. i.e., they've broken a leg, they've broken an arm, they've had a wound, they're post-op. The tricky one becomes, is it appropriate to prescribe an opioid for anyone with chronic non-cancer pain? That's a more difficult issue. Usually I say no, especially in someone with an opioid use disorder. But there is some evidence that really up to morphine 60 milligrams is tolerable, but certainly above morphine 60, you would not give opioids to chronic non-cancer pain. It's very complicated, but make sure you get a permit and try and minimize less than 60. That's what I would say.
Yeah, I mean, that's more practical advice. I think I was trying to have a more sort of philosophical debate, but we were out of time, so perhaps we're out of time for this at another time.
All right. Thank you, Richard. That's all for today, folks. My name's Dr. Ferghal Armstrong, and this has been Cracking Addiction.